Strada Street Food. Taste the vibe. Taste the tradition.
Radio Al Ansar, Durban, 90.4 FM. Peter Maritzburg, 105.6 FM.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والعاقبة للمتقين والصلاة والسلام على رسوله الكريم سيدنا محمد وآله وأصحابه أجمعين برحمتك يا أرحم الراحمين. All praise due to Allah, the Lord, cherisher, nourisher, Allah guide us. Greetings, salam, salutations on our beloved Nabi Muhammad Rasulullah sallallahu alaihi wasallam. It's time for Medical Files, brought to you by the Islamic Medical Association of South Africa and hosted by myself, Faisal MJ Sulaiman. Assalamu alaikum wa rahmatullahi wa barakatuh, and we welcome our listeners to Medical Files on Radio Al Ansar, CII Radio, Voice of the Cape, Radio 786 Sirius FM, Radio Islam, and IFM Port Elizabeth, and all listening to us on audio streaming on Facebook and all other platforms. Our topic for discussion is disease of the lower gut, and our very special guest this evening is Dr. Yusuf Mullah, a gastroenterologist. Yusuf Mullah, Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakallah khair for joining me on the program this evening.
Wa alaikum salam wa rahmatullahi wa barakatuh. Jazakallah, Brother Faisal, and Jazakallah for the invitation to discuss this topic this evening.
I must thank you for joining us as well. It's an important topic, something that affects all of us, but somehow many of us just take these things for granted.
Yes.
Just to introduce our guest, Dr. Mullah currently practices at the Gateway Center for Respiratory and Gastrointestinal Disease at Gateway Hospital and Life Mount Edgecombe Hospital, and is a member of the South African Gastroenterology Society and the College of Physicians South Africa. He holds an MB CHB degree from Pretoria, a Master of Medicine UKZN, Fellow of the College of Physicians South Africa, Diploma in HIV Management South Africa, Diploma in Geriatric Medicine South Africa, Certificate in Gastroenterology South Africa, and we're very fortunate to have him with us. Dr. Mullah, just to start off the discussion, we did say our topic for discussion is disease of the lower gut. Just for my personal knowledge, what's the difference between a colon and a gut?
Yeah, so I think you just a simple phrase to describe our intestines. When we use the word gut, we normally will discuss of the upper gut, which will be the stomach, the esophagus. When we speak of the lower gut, it will mean our small intestines and our large intestines. One may discuss the liver, the pancreas as well with the upper gut. Just a term to discuss these conditions. We normally will like to discuss the upper gut and lower gut separately, because the diseases are quite separate and distinct in those two segments.
So having said that, then what is the function of our colon?
Yeah, so if we look at the colon, alhamdulillah, we have the small intestines and the large intestines. Mm-hmm. And the small intestines, the primary role of that is to help assist our body in digestion and absorption of nutrients. So with digestion, we ingesting proteins, we ingesting fats and carbohydrates. The gut has enzymes and a microbiome, millions and billions of enzymes in there. And this will allow us to digest food. And the lining of the small intestines will allow our body to actually absorb that. We will absorb our iron, we absorb our nutrients, our calcium, our electrolytes. The large intestines play a role more for water absorption primarily, and it allows us to form fecal matter and allow our body to get rid of waste. So alhamdulillah, we have this body with the gut that serves a vital role. And when we see patients with disease of these organs, then we as medical practitioners truly appreciate the role that the intestines perform.
Now, we intend discussing different diseases of the lower gut. Let's start talking about inflammatory bowel disease. What is inflammatory bowel disease?
That's a good question. So inflammatory bowel disease, it's a distinct condition that has been described decades ago. And this condition is regarded as an autoimmune condition. It's a condition where certain individuals, Allah knows best, are genetically predisposed. And over the years and over the decades, now with multiple Western factors that has come into play, the trigger that occurs in an individual who is at risk. And when this trigger occurs, these patients then activate the immune system, to put it simply. And when this cascade gets activated, the body attacks itself, if I could put it in simple terms. And if we talk about inflammatory bowel disease, we speak distinctly often of ulcerative colitis and of Crohn's disease. Those are two distinct entities. Crohn's disease may affect the small intestines, they may affect the upper gut and the colon. They often would almost involve the end part of the small intestines. While ulcerative colitis affects the large intestines, the top layer of the intestines compared to Crohn's, which affect the lower layers. So they have distinct presentations, they may have distinct complications, sometimes similar treatment modalities. But it's one of those conditions that humble us as gastroenterologists. It's a very complicated disease in some individuals, because the disease may be mild, it may be moderate, and unfortunately, in some patients, it may be severe.
Now, having said that, how can you present? I mean, as a layperson, how do I know that I'm probably having this particular condition?
So as we said, the disease affects those organs. So if you look at ulcerative colitis, it affects the large intestine. So patients primarily will present with symptoms related to that, which will involve, for example, chronic diarrhea. They may present with diarrhea that is not resolving. Diarrhea that often would have mucus, often would have blood. If it's a prolonged episodes, patients will have loss of weight with this. They may have abdominal discomfort and symptoms of bloating as well. Crohn's disease often presents more with pain. It can also present with diarrhea depending on which area is affected. And these conditions, from the autoimmune nature of it, interestingly enough, some patients may present with things outside the intestine. So they may present with arthritis, they may present with certain rashes, certain eye inflammation conditions, they may present with abnormal liver functions. So again, it's a very interesting disease. It affects organs outside the colon, primarily the colon, but those will be the primary symptoms that if patients have. It's not your regular tummy bug that you had for 1 or 2 days, some nausea, vomiting, eaten out and had some gut infection. This is a more prolonged presentation that is not remitting.
We're discussing disease of the lower gut. Our guest this evening is Dr. Yusuf Mullah, gastroenterologist. And if you have any questions for Dr. Mullah, you may forward them to us via WhatsApp on 060 904 1056. That's 060 904 1056. Now, Dr. Mullah, we will continue with inflammatory bowel disease. How is this condition diagnosed?
So primarily the patients would often present to the family practitioners, the GPs. They will get assessed. And if it's a non-resolving problem, they would often get referred to the gastroenterologist. And once patients get referred to the gastroenterologist for the prolonged episode, there's a few things. Often patients will have this clinical picture as I've described. Patients may have a family history. And once they tick this clinical box, we often may look for non-invasive markers. This may involve blood markers of inflammation. There's also stool markers of inflammation that can be sent off. Ultimately, the endoscopy is the test of choice to make the diagnosis. So one does a colonoscopy. And when one does a colonoscopy, there's distinct features that we would see that will imply that this looks like ulcerative colitis or Crohn's disease. I don't want to get too much into that. It gets complicated, but there's distinct features on colonoscopy that can be described. Imaging may assist, but isn't the first or isn't the gold standard test to make a diagnosis. When I speak of imaging, I'm speaking of CT scans and MRI scans. It can assist the diagnosis and look for complications, but often your colonoscopy would be your ideal gold standard test to make diagnosis.
Now, having said that, you've now diagnosed the condition. Does it need to be treated, or can it sort itself out?
Yeah, that's a good question. That's a good question. So, definitely needs to be treated. If we have a mild patient, patients will need symptomatic control. So we don't want them to have the diarrhea. They often have urgency. When you get on control of that urgency, we don't want them to lose weight, to have malnutrition. So one has to treat it for the patient's symptoms, that is the acute symptoms that they're going through. The second reason is to prevent the complications that we are aware of related to this condition. And those complications are localized to the colon. For example, patients may have narrowing of the colon. Patient may have severe anemia from prolonged inflammation and bleeding. And the nasty one is that if there's non-remitting inflammation of the colon that's ongoing for a long period of time, it does predispose patients to colon cancer. So they're at risk of that. So we should treat it to make them feel good and to prevent these complications.
You're talking about treatment. How is it treated?
So there's different ways one looks at this, and we often, when seeing patients, we would stratify them. So we'd stratify them as having mild disease and what level of the colon is affected, and then we would give treatment. There is medical treatment available. One may have to use, unfortunately, steroids initially if it's a bad episode. Then we transition to medication that is steroid sparing. These medications on the milder side of things may just line the colon. There is suppositories and tablets that will just work and not get absorbed that much, but will cool or calm down the inflammation. If that doesn't work, unfortunately, one needs to use immunomodulators, which now is immunosuppressive medication. So that autoimmune pathway that we spoke about, it hits it at that level. And we even now have what we call biologics, and there's an array of biologics available. These medications are expensive, very targeted, has a particular design. They infusions, they are tablets, and they are injections that can be used. So very advanced medical treatment. But in saying that, Brother Faisal, there are patients that unfortunately would not respond. And we would escalate treatment rapidly in them. As they are not responding, we would try the next one, and we would increase the dosage. We'll try the next one. We'll check for antibodies. We'll check for complications. So some patients, unfortunately, will earn surgery if medical treatment is not working. It's a refractory disease.
Now, is this something that is common? I mean, many people suffer from it, or?
That's an excellent question as well. So it's a disease that was described in our country in almost the 80s. It was more discovered in Cape Town, and then we saw some articles that came out from Baragwanath Hospital in African patients native to the country. So genetics is very, very interesting. But over the years, it has become much more prevalent. The reasons for that, we think, is we're more aware of the disease. There's more specialized people doing procedures to find the disease. And as I mentioned with the genetics and the trigger, which is the trigger of it is not known. Environmental, westernized lifestyle, from environmental toxins to things we're ingesting, unfortunately, may be increase the prevalence. So we find that in the lower income countries, it's becoming more prevalent, and we're now reaching to the level of what Western countries had previously.
I was going to ask you what are the causes of this, but I think you did mention you don't know what triggers it. But having said that, I'm sure there must be some preventative measures that some can take, or especially who does this present in? Is it adults or is it males? Oh, yeah, obviously,
yes.
Yeah. Is it adults? Yeah.
Yeah, that's a good question also. So the main group of incidents where it'll be, you'd find it as the highest sort of prevalence initially, the incidence would peak from the 20 to 30 age group. Around that age group, you'd see it almost peaking. It can present in the pediatric age groups, patients in the teens and even younger than that. But we also see it in patients much more older in age. So patients over 50 years old, for the first time, we're seeing inflammatory bowel disease in them. They've never had that disease before. They've had even scopes before. So more prevalent in, let's say, the ages 20 to 30, less prevalent below that age. But we, of course, know there are many cases, and in the elderly, we see it as well. So it's quite a wide range, but the classical age will be more of that younger age group.
Mm-hmm. Let's just move on to diverticular disease. What is diverticulitis?
So diverticular disease, so that's a disease that we see in the large colon primarily. We can see it in the small colon. It's not so common actually. And this disease is if you had to imagine the colon and you're going through a tunnel and it's like a pipe, this is where you would see almost like potholes in the colon. That's what it actually would look like. If you're looking at a video, it looks like potholes. When reading a scope, we can see it looks like that to us. It's a lot of theory from the 1940s and 50s that said whether it was related to constipation or whether constipation came first or came after diverticular disease. It happens in weak areas of the colon, anatomically weak areas of the colon. So we often would see it present in more elderly patients, although it can happen in younger patients. Mm-hmm. It's these little potholes in the colon, and unfortunately, it can cause problems. So patients may have asymptomatic diverticular disease, where it's found incidentally. Patients may have diverticular disease that's presenting with symptoms of abdominal discomfort, abdominal bloating, and constipation. And unfortunately, it can complicate. If it complicates, it can get inflamed. We call that diverticulitis. And Faisal, their patients would have fever, they'll have abdominal pain, they may have diarrhea, don't really have to have diarrhea, but the fever, abdominal pain will present them to hospital. CT scans and imaging will show us there's diverticulitis that requires antibiotics, either oral or intravenous with fluids and resting the bowel. And those can complicate, unfortunately. It can create a burst in the colon, cause what we call a perforation. It can create an abscess that requires antibiotics and drainage. So it's not a completely benign disease, but most patients that have it probably don't even know they have it.
No, you said they don't even know they have it.
Yeah.
So is there a particular age group who should be testing for this? If I can use the word testing,
Yes,
screening for
yes.
it rather.
For diverticular disease, there isn't any criteria internationally to say we should screen for it. If patients have abdominal pain and they get imaging and it's an obscure cause, one may find it on colonoscopy. So we shouldn't really screen for it. In terms of age group, the prevalence is more in the elderly patients compared to the younger patients.
Okay. We're going to visit the marketplace. We'll continue after this. To stay with us.
This hadith is sponsored by Ashraful Aid, International Humanitarian Organization.
Sunnah a day, it is sunnah to lick one's fingers and clean one's plate thoroughly after finishing a meal.
This hadith is sponsored by Ashraful Aid, International Humanitarian Organization.
With Ashraful Aid this Ramadan, your zakat changes lives. It feeds families facing hunger, restores dignity to those in need, and brings hope where it is needed most. From food relief to essential support, your zakah reaches communities with care, transparency, and impact. Give with confidence, give with trust. Make your zakah count this Ramadan. Give your zakah to Ashraful Aid and help change lives today.
Sunnah a Day, proudly brought to you by Sunpick, 100% pure sunflower cooking oil. Sunpick, cook more with less.
Hadith a day. قال رسول الله صلى الله عليه وسلم الصلاة عماد الدين. Salah is a pillar of deen. Salah is the most important form of ibadah. When we perform our salah, we are showing our obedience to our Creator. Salah is the key to Jannah.
Sunnah a Day, proudly brought to you by Sunpick, 100% pure sunflower cooking oil. Sunpick, cook more with less.
Imagine this. You're putting together a 7-color meal, from the creamy pasta to the glazed carrots and flavorful onion gravy. This entire meal is made with our 100% pure extra virgin olive oil from our La Familia range, bringing outstanding quality and taste to your kitchen. Shop La Familia 100% pure extra virgin olive oil at any leading supermarkets near you. La Familia, heart of the home.
Radio Al Ansar, Durban 90.4 FM, Pietermaritzburg 105.6 FM.
You listen to Medical Files, and the Medical Files is brought to you by the Islamic Medical Association of South Africa, hosted by myself, Faisal M. J. Suleiman. Our topic for discussion is disease of the lower gut, and our special guest is Dr. Yusuf Mullah, a gastroenterologist who currently practices at the Gateway Center for Respiratory and Gastrointestinal Disease at Gateway Hospital and Life Mount Edgecombe Hospital. He's also a member of the South African Gastroenterology Society and the College of Physicians South Africa. Now, just to remind you that doctors and guests on the Medical File program will help you with any medical problems you pose by giving you advice on air. However, they do not have your full medical history and have not examined you. Please verify the advice given to you on air with your regular doctor who knows your medical history, allergies, etc. Neither the doctors nor the relevant radio station nor the Islamic Medical Association of South Africa will take any responsibility whatsoever for any adverse reaction caused by the advice given on Medical Files. Now, Dr. Mullah, we were discussing diverticulitis or diverticular disease. Now, what are some of the common symptoms of diverticulitis?
So patients may be asymptomatic. Patients may have patients similar to IBS, which I'm sure we'll get to. Patients often will present with abdominal pain. So if it's troubling them, they may present with abdominal pain. There's a subtype of patient that may present like colitis, what we spoke about earlier, where they may even have diarrhea. And if it's complicating, that's where we see now fever and shivering and feeling very, very unwell.
060-904-1056. If you have any questions for Dr. Mullah, you may forward them to us via WhatsApp. That's 060-904-1056. Now, Dr. Mullah, you mentioned IBS. What is IBS and how does it present?
Yeah, that's an excellent question. So IBS is short for irritable bowel syndrome. This condition is it's a functional condition. So all around the world, we use criteria to make the diagnosis for this condition. And if we're looking at a patient and we're going through their full history and we're going through all the symptoms that they're presenting with us, we look for certain features that are particular. Number one would be patients that have altered bowel habits. Either it's constipation or it's diarrhea. Patients would have abdominal pain that's very non-specific and like a discomfort. Patients may have severe bloating. And the symptoms are there for a prolonged period, at least more than 3 to 4 months. Often it's much longer. And whatever test your physician, your doctor will do would actually be negative. So if you're looking for food allergies, if you're looking for gluten diseases, if you're looking for colitis, diverticular disease, etc., the test would come back clear. You may do bloods and stool tests, may do imaging, may do endoscopies, even biopsies. We don't find anything. They would tell the patient, well, this is irritable bowel syndrome. Not every patient will need all those tests. Often if it's a young patient, a certain phenotype, we may do some basic tests. In the older patient, we may end up doing more tests because we worry about other more sinister diseases. But once we have everything cleared off and the dietary history is taken fully, there's no lactose intolerance, there's no gluten sensitivity problems, we term it as IBS. And then we go ahead counseling patients as to how we should manage it.
Mm-hmm. Now, you did mention how you make the diagnosis by elimination, by process of elimination. Yeah. But who makes this diagnosis?
So it can be made by our general practitioners initially. We speak of red flags in medicine. So if patients are losing weight, for example, if they unexplained anemia, if the pain is extremely severe, on examination, if there's certain findings that they find, then those patients would get referred on for tests. But if they're doing a clinical assessment and if they're doing basic bloods and basic ultrasounds, for example, and things are relatively normal, they may call it's probably IBS, manage it and follow up. So a general practitioner can definitely make the initial diagnosis, but on follow-up, if things are now looking slightly different and worrying, patients usually should be referred on to the local gastroenterologist, who then would do a bit more precise tests to exclude other diseases.
Question comes from a listener, and the listener wants to know, is IBS caused by stress?
Excellent question. Excellent question from listener. So, the gut and the brain axis is something that's been well described, is well known. Our emotional areas flare up when IBS patients have abdominal pain. So those symptoms that I mentioned about change in bowel habits, bloating and abdominal pain, the triggers for it, one of them correct would be stress. So if I give you one example, if a patient that has bad IBS and has the diarrhea type of IBS, that IBS that gives you urgency and gives you diarrhea, and they're going for the mid-tick exams. So the night before and the morning of the exams, they'll probably go to the bathroom 10 times. That's classical. After the exam, they're much more settled. Those stress hormones and that heart rate and anxiety has now gone, and they're much more settled and they're back to normal. That's a classical example to use. Unfortunately, some of the chronic stresses that are there in daily lifestyle, plays a role. And part of our treatment plan in certain individuals will involve addressing that.
Having said that, how is this condition managed?
So we would classify it, and if patients are labeled as irritable bowel syndrome, diarrhea type, for example, all those criteria and more is what we would target. So if it's diarrhea type, for that loose stool, one has to try to manage it. There's certain stool forming agents that can be used at times of diarrhea. Sometimes patient may have to use anti-diarrheal tablets if it's really flaring up and really bad. For the abdominal discomfort, we often would advise antispasmodic treatment, such as your Buscopan, etc. There are many other ones available that are antispasmodic agents. For severe bloating, which is the most trickiest one to manage, often diet manipulation is the one that would assist that. And your fermentable foods, Faisal, are the one that we need to just watch out for in these individuals. And I always tell patients that some of these foods are actually, in inverted commas, healthy. So your high fiber foods are actually insoluble, most of them. So your high wheat cereals, your high fiber breads, very insoluble. So if you're a patient prone to bloat, you can bloat with that. Your green leafy vegetables, green beans, your cauliflower, your cabbage, very bloating foods. Your dals, your beans. So these foods are fermentable, a part of the fermentable food group. We're not saying patients shouldn't have it, but should have less of it. That's for the bloating, for the pain and the spasms we discussed, for the diarrhea we discussed. In the constipation phenotype, patients may unfortunately need to use a stool softening laxative in a chronic basis if they have really bad IBS that is chronic. And we often use stool softeners because it's much more better tolerated and patients do not get used to it. That we would advise. And as we said about stress, certain relaxing activities, certain exercises, good sleep, avoiding stressful activities, and if patients have serious mood issues, that also should be attended to assist that gut-brain axis.
You mentioned stool softeners. Are there any side effects of this?
So stool softeners, of course, can cause diarrhea. Some of them may not taste so good. One, if you're using really mild stool softeners, like, for example, lactulose, these stool softeners often would not lead to electrolyte disturbances in individuals and can be safely used even in kids almost, in elderly patients. The more stimulant laxatives, which we don't like to use. These are small tablets, some of the suppositories, I don't want to mention the name on the radio, but these ingredients can create a bit of active gut where one can get spasms and get cramps from it. And you can get a bit used to it, unfortunately. So those are the ones we don't like. The softeners are relatively safe. We always would like patients to, increase for constipation, increase their water intake, be active, be less sedentary, to have healthy food, especially the fruits and the salads, and have a bit more of an active lifestyle. Unfortunately, what we see with the youth nowadays is, of course, the rise of junk food. And now they call it ultra processed food. And that food group is counterproductive to a lot of the diseases in the gut.
Any preventative measures that one can take?
For IBS, not really. Often it's that certain personality phenotype. It's a certain type of individual. I think preventative-wise, the only focus could be the diet to avoid anything that will irritate the gut, avoid anything that will bloat the gut, avoid things that will constipate or cause diarrhea. If I had to touch upon diarrhea and the diet as well, so certain things that we may not think about is the use of certain artificial sweeteners that can actually cause a bit of osmotic diarrhea. Certain spicy, strong food in certain individuals can create a problem. Very strong or high amounts of caffeine can actually increase our rectal or our gut urgency. So while some may tolerate it, certain of these foods may trouble people. Many people don't like too sour or too citrus foods. But the caffeine, the stimulant type of foods, one should best avoid if you got the diarrhea type of prone gut.
Now, a few times you mentioned the word colonoscopy during our discussion this evening. Now, what is a colonoscopy? Why does one need a colonoscopy? Who does this?
Yeah, that's also an excellent question. So colonoscopy is a procedure that one does by inserting what we call an endoscope. So it's a scope that's rubberized, that's designed to enter from the bottom passage. It's designed to look at the entire length of the colon. So the large colon is what it looks at. So patients basically are prepared the day before. They'll meet the doctor a week or two before that and discuss about the risks of it, the benefits of it. They prepare the day before. When they come into the hospital or the day procedure rooms, they would get a drip put up. They would be given medication that puts them off to sleep, almost amnestic. So they're quite relaxed and their gut is clean and prepared. The specialist would then put in a endoscopy at the back passage, and the aim is to look at every centimeter, every millimeter of the large colon. So when viewing this, we can detect most of the diseases we spoke about this evening, diverticular disease. We can detect colitis, be it Crohn's, ulcerative colitis. And, the reasons for doing the scope is actually to look for colon cancer and for polyps in many of individuals. And that's sort of a very, very important reason to actually do the colonoscopy. It may have some risks. Some patients may wake up a bit bloated. Very rarely there are high risk issues where there can be bleeding. One can perforate or cause a hole in the colon, cause damage to the colon. It's regarded as generally a low risk procedure, but it should be done in experienced hands, and often your gastroenterologists, your surgeons, your colorectal surgeons are trained to perform these procedures.
Now, you use the word polyps.
Yes.
What are polyps, and if you find some polyps, well, how do you deal with it?
Yeah, excellent question. So with polyps, colonic polyps, so colonic polyps are little growths, little blebs, little growths that would occur in the colon. So it has been described in patients that are more older in age. So as we get older, we get these lumps and bumps. So these are one of the bumps that you get in the colon. And these polyps can usually are benign. So they're not cancerous at all. But some types of polyps can unfortunately transition and evolve into a cancer. So for example, if we're screening patients at age 50 and above, and we find polyps, Allah knows best, we would remove it at time of endoscopy. And that potentially will lower the risk of colon cancer in that individual. And with the evidence that we know in the Western countries, it actually has decreased the prevalence of colon cancer by doing colon screening and polypectomy, removing those polyps. So that's what a polyp is. It's a bit of a growth that can become a problem. We should screen for it, and if we see it, we remove it at time of endoscopy.
Now, we use the word colonoscopy, you use the word endoscopy. Now,
Yes.
what's I know of, as a layman, endoscopy is when you do something.
True,
in the
that's
mouth.
true.
The colonoscopies are using it interchangeably.
No, 100%. So the actual scope we use, if you be technical, we talk of the top scope that goes to the esophagus, goes to the mouth, esophagus, stomach is called the gastroscope, and that's called gastroscopy.
Okay.
The one that goes to the bottom passage is called the colonoscopy or the colonscope. When we generally referring to the scope that enters to the orifice, we would just say endoscopy. It's more of a generalized term. But to be technical this evening, as we alluded to, we're talking about more colonoscopy.
Okay. Now, thanks for the clarification. Okay. Now, let's discuss colon cancer. Now, once you've done your colonoscopy and you find that this condition exists, what's your next step?
Right. So with colon cancer, a few things to mention about colon cancer. It's of course a cancer of the colon. It can be different areas of the colon, and the prevalence of this has been increasing, unfortunately. It's also been alluded to with certain lifestyle and certain environmental triggers. Smoking is on that list, which often people forget about. Unhealthy eating, overweight is actually one of the other risk factors that we don't pay too much attention to. It's becoming more prevalent because we're doing more scopes, we're finding it more. But interestingly enough, not only in our country, but overall, it's now becoming more prevalent in the young age group. A lot of research should be done to figure out why is it now presenting in the young age group. It is advocated by guidelines overseas that from the age of 50, one should be screened for colon cancer. When we do that scope, if we see a polyp, we remove it. If we see a more nasty looking growth, we would biopsy it. When we take that biopsy, we of course take pictures, we document where it is and the extent of it. We take that biopsy. Once that biopsy comes back as colon cancer, we would counsel the patient. Then we would call our surgical colleague in, preferably for the colon, our colorectal surgeon, ideally, and the oncologist. So we form a bit of a team. From the medical side, we would make sure the blood levels are fine. From the oncology side, we often would end up doing imaging to see if it's only in the colon or it has spread. Because remember, with cancer, it can be localized or it can be metastatic. It can spread to other organs. And then we plan with the surgeon what is the best line of treatment. Certain individuals may require surgery up front. Some patients may require the oncologist to give chemotherapy or radiotherapy. And often it's a bit of a teamwork type of thing in these patients. But the more earlier one does the scope, the more, Allah knows best, the more better chance one has because you're detecting an early cancer.
Now, if you find that somebody had this polyps when you're doing your colonoscopy, what happens next? I mean, you've treated this, you probably, gotten rid of one or two of those polyps. But now, does one has to continuously have themselves checked out?
Yeah. So once we remove a polyp from a patient, we go to a bit of a classification with that polyp. We look at the number of polyps we took out, we look at the size of the polyps, and it goes to the lab, so we find out the actual type of polyp. And then we would classify that risk in that particular individual. Patients that have, let's call it high-risk polyps, very high risk, may require a scope in the following year to make sure that the rest of the colon hasn't gotten a polyp, and where you took out the polyp, it hasn't regrown. Patients that have a bit of a low-risk polyp, they may not necessarily need a scope next year, but they definitely will need a surveillance or interval scope a few years down the line. It does depend on what scoring we use and what exactly we classify those patients. But that is correct, Faisal, we should repeat the scope, but we would just see whether it needs to happen in a year or 2 years or 3 years.
Mm-hmm. Now, very often we find that somebody's been diagnosed with colon cancer, but now they give it different stages.
Yes.
And we find that, it's too late.
Yeah.
Now, are there any symptoms that it presents with that one could detect it early?
Yeah. So if you're doing the scope early, we're hoping to find it in patients that are asymptomatic. So it's very early, and you can act on it early. We've done that many times. Unfortunately, patients that come too late to hospital, as you're saying that it's too late, they would present with certain types of signs and certain type of symptoms. So often these patients would give symptoms of weight loss. That's the one thing you'd find. Patients may have a family history of cancer. These patients may be pale, maybe feeling weak, maybe shortness of breath, because with these malignancies, they often will have anemia that will present with it. And depending on where the cancer is and depending on how it's impacting locally, one may have pain in that area, one may have change in their bowel habits. When you examine them, you touch certain areas, you can feel something and it's quite sore. So that's often how they may present, especially in the latter stages.
Mm-hmm. We're going to visit the marketplace once again. We'll continue after this, inshallah.
At this time of trial and worry, the blessings of charity are the ideal means to avoid calamity and despair. The Al-Imdad Foundation gives you the opportunity to sponsor a share in a borehole in South Africa for just 1,000 Rand and provide what the Holy Prophet, peace be upon him, called the best form of charity. Donate online at alimdad.com or call 0861 786 243 for more information.
At the new Checkers Saxony Westwood, you'll find everything from our signature steakhouse classic cuts, expertly aged and ready for the braai. Try something exclusive like our Simple Truth certified lamb, responsibly sourced, free range, and raised without added growth hormones or promoters. Checkers Saxony Westwood, butchery, bakery, and deli, certified by the NIHT. Doors open on October 30th. See you there.
The trucks have arrived and stocks are in. Yes, Wonder Dates have the largest variety of dates from Medina, Dubai, Iran, Tunisia, and Namibia. They stock a huge range of spices, nuts, dried fruit, and best of all, your Ramadan goodies. The best prices. So for everything nutty, nibbly, chewy, munchy, spicy, sweet, sour, and savory, make a date with Wonder Dates, bringing the freshness of the farm to your home. Remember our new address, 9 Peters Road, Springfield Park, Durban. Contact us on 031 577 7722. Call now.
Attention bargain hunters.
The Simplex Radio Blitz sale is now on.
Upgrade your entertainment with unbeatable TV deals.
Get a Hisense 43-inch LED TV for just 2,999.
A Samsung 55-inch LED TV for 5,999.
A massive Samsung 70-inch LED TV for 8,999.
Or go big with an LG 86-inch LED TV for only 15,999.
Hurry! Limited stocks available.
Sale ends January 31st.
We guarantee to beat any advertised price or written quote.
Simplex Radio.
Simplex Radio, the name you can trust.
Get ready to elevate your fitness game at First Fitness in Durban's Berea. With a spacious free weight area, award-winning equipment, and exclusive ladies-only parking and training level, we've got everything you need to crush your goals. Hit the ground running on our outdoor track or unleash your inner warrior in our MMA and boxing dungeon. Plus, enjoy high security and ample parking. And don't forget to refuel at our halal coffee and health restaurant for the best in coffees, smoothies, and healthy eats. Join us today and redefine your fitness journey. First Fitness, dare to be extraordinary.
Radio Al Ansar, Durban 90.4 FM, Pietermaritzburg 105.6 FM.
You're listening to Medical Files, brought to you by the Islamic Medical Association of South Africa and hosted by myself, Faisal M.J. Suleiman. Our topic for discussion is disease of the lower gut, and our special guest this evening is Dr. Dr. Yusuf Mullah, a gastroenterologist practicing at the Gateway Center for Respiratory and Gastrointestinal Disease at Gateway Hospital and Life Mount Eskom Hospital. This is an interactive program. If you have any questions for Dr. Mullah, you may forward them to us via WhatsApp on 060-904-1056. Now, Dr. Mullah, just prior to Advik, we were discussing colon cancer, discussing screening as well. Is there anything you'd like to share with us on this particular concept?
Yeah, so in terms of screening, as we alluded to, that patients should get screening done. These are well patients. When we say screening, we're talking about patients that are not having symptoms, patients that are actually feeling well, but by virtue of the age, their risk profile has now increased where we should be looking for these polyps and looking for cancer. We should start at age 50, ideally. Previously, they spoke of older ages. And now in certain groups, we're actually going down to age 45. In certain areas, certain societies are advocating for that. But in patients that have symptoms, and you asked that question, we alluded to that, these patients are not screening now. These patients require that because they're having symptoms. So age doesn't really matter. If I could use an example of what I was faced with a few years ago, we had a patient, a medical practitioner who wanted me to do screening for their parents. So on the same day, we brought the parents in. The mom was just feeling weak and she was slightly anemic. She was over 60 years old, and the dad had some mild abdominal pain. So on the same day, we said we'll do both of them. We did quite quick, within a few days, we just come in and we do it. So on the patient, on the colleague's mum, we did gastroscopy. That's a scope from the top.
Okay.
Once we went into the stomach, unfortunately, we saw a gastric cancer. A rare, terrible-looking lesion that was bleeding. We took biopsy. This was classical and typical of a gastric cancer. And we had to counsel them afterwards. But the next patient that came in was her husband.
Yeah.
And on his colonoscopy, we actually saw colon cancer.
Oh.
So it's absolutely heartbreaking because we saw a couple, one with gastric, one with colon. But more old in age, Allah knows best, they missed their screening time when they were having symptoms. They came in now when they're having symptoms, pain, and one had anemia and feeling weak. And we didn't have to counsel, of course, one of my colleagues with regards to what's the next steps of management for this. And it was extremely emotional and heartbreaking to see this. And this is the reason why we encourage our general practitioners to refer patients to gastroenterologists, to colorectal surgeons, to surgeons to get scopes done for screening. We advise the community to get these things done because, again, with our knowledge, this is us being cautious with the knowledge of these diseases.
You'd rather be cautious and take the necessary preventative measures if necessary. Now, getting back to general gut health, what dietary changes can improve gut health?
So with dietary changes, that's a nice broad question. Overall with gut health, we still will discuss in terms of healthy eating habits. And with symptoms, and especially look at like IBS phenotype, overall, patients should avoid unhealthy foods. Our foods rich with sugar, unfortunately, predisposed to many pathologies and many diseases. Our sugary flavored beverages, the classical example, which is overused, our junk foods, from our chocolates to our sweets, our ultra-processed foods. These foods are unfortunately unhealthy with low nutritional value and cause more harm than good. So the first thing we should do is avoid, let's call it inverted commas, the junk food. We should incorporate balanced eating. So patients should make sure that they're having enough protein in their meals, they're having healthy fats from fruits, they're having the good roughage from the salads and the vegetables. And if you're looking at a plate of what we're eating every day, we should really see where our plate is divided cautiously. We should avoid the sugary drinks, as I mentioned. And, overdoing certain type of food is also not good. So patients that would overdo red meat, that can lead to other issues. Processed meat, we talk about fatty liver disease with these type of things as well. So really a balanced diet with not so much of unhealthy foods. We all will have a cheat here and there. And overindulge in something that, we shouldn't be doing. And Islam teaches us for moderation. And if I could use one example there, since we're talking about diet, many patients in our community would have excessive amounts of tea. And not knowing that with tannin and with tea, you actually can impair absorption of our nutrients, absorption of our minerals. So overindulgence should be avoided.
So cut down on the tea.
And in Ramadan coming up, even the halim, with the burping, the brother should just take it easy on the halim.
Okay. Salams, how would one know how and where one is losing blood from internally? No blood is noticed in stools. Can anemia cause that?
Yes. So when you speak of anemia from the gastroenterology gut side, often the anemia we will get worried about is iron deficiency anemia, and that can be part of many different reasons. If you just look at iron, for example, either one is not consuming enough iron, either one is consuming iron and not absorbing it. So the tea was one example I gave you now. There are certain autoimmune diseases of the lining of the stomach can prevent this. Certain infections of the stomach like H. pylori that can cause this. Certain small gut immune diseases like celiac that can prevent absorption. So there are specific diseases for absorption. And lastly, which I think the caller is alluding to, is can we be losing blood somewhere? Yes. In the stomach, one can have ulcerating diseases. One can have large gastric polyps in the stomach. One can have cancer in the stomach. So these are things that will cause bleeding. In the colon, all of these we spoke about this evening, from colon cancer to very large polyps to bleeding diverticuli. These are things that can cause bleeding. If one had scopes done and they are normal, then we should look at the small intestines, because they are very, very difficult to diagnose conditions which can cause this occult type of bleeding. And these can be simple things, to put in a simple terminology, small blood vessels, like one is getting nosebleeds internally. So that condition can also cause occult bleeding. We don't actually appreciate blood loss in the bathroom, but the blood count can be dropping from a form of blood loss.
Okay, another question that comes through is, how will I know my gut microbiome is healthy? Are there tests to determine this?
So gut microbiome is a buzzword for the last 10 years in the community. So it's really something that's evolving. So to answer that question, so to know whether it's working, I would say we need to look at any evidence of maldigestion. So if one is absorbing all the nutrients, they're not having deficiencies of the vitamin D and iron and folate, etc., that means absorption is happening, and that's good. And with malabsorption, one will often bloat and have non-specific symptoms. One is not having that, we could assume there's a healthy microbiome. There are tests available. Some of these tests are quite expensive. Some of these tests are sent internationally. We do have a few research labs that are doing it in the country. But the issue with these testing for now is that we don't have any criteria to really interrogate it, to give firm advice on the findings of these tests. So at this moment, we don't routinely recommend doing microbiome testing. The future, this may change.
Okay, the message for you from my brother Daud Asmal, a friend of yours, and he says that your cheat day is on Saturday, and your dessert awaits you. Okay, another message comes. Okay, I think it is personal. Okay, it says, if my mum and grandfather has history of colon cancer and cancer, etc., what best can we do to safeguard and prevent this for us? Also, is one cup of coffee a day bad?
Good question. So with regards to the family history, it's very, very important. So I think from the prevention point of view, to just ensure there's screening done. If the cancer was in an early age in them, one should do the screening a bit more earlier than the recommended guidelines. In terms of the risk factors for colon cancer, I mentioned some of them: overweight, unhealthy food, ultra-processed food, and we also mentioned smoking. So those are the lifestyle things that one should do. So basically exercise and have healthy lifestyle. On the prevalence studies, those things are much more higher found in patients with colon cancer. From the pure genetic side, screening is really the only thing one could do. As I said, polyps may be one pathway to the cancer. So if one had to screen early and remove polyps, if it's there, Allah's best, it can be removed, and that can potentially prevent it. The coffee question, so I did mention in IBS, it may be a trigger, but it can be well tolerated. So it's not bad for health. In fact, certain conditions, for example, fatty liver disease and liver cirrhosis is actually shown to assist the liver. In particular, 2 cups of coffee, either caffeinated or decaffeinated, the antioxidant effect has been researched and shown to help. But I think if one can tolerate it, with the gut and coffee, often the blends and the types may irritate certain individuals, and certain individuals can tolerate it. 1 cup is absolutely fine if tolerated.
Okay. Salams, doctor, can cancer blood tests show if one has colon cancer?
So there are tests available for cancer screening that is not part of scopes. So there are cancer blood markers. The issue with these blood markers is its sensitivity, unfortunately, is poor. So we do it in patients, a specific group of patients, so we can track it if they have colon cancer, but it's not recommended for screening purely because if you had to do the test and somebody's sitting with the cancer in front of us, that test could be negative, plus minus 50% of the time. So we would not use it for screening. There are stool tests. Want to send a stool sample for blood that can be part of screening. There's also tests nowadays with the stool that one can check for other type of genetic material that can also assist for screening. With the blood test, unfortunately, at this stage, we don't have a reliable blood tests that can replace the scope.
Okay, many questions are coming in, but unfortunately we have a minute left. Very quickly, Jazakallah for your advice. Can worms cause problems and can those parasites migrate to the brain? Jazakallah, appreciated.
So with worms, the helminths we're speaking, there's different types of worms, quite a lot to get into there. These definitely can cause problems in pediatric age groups. We do see it in the elderly patients as well. It can create malabsorption, so patient may present with iron deficiency. That's the most common type of presentation, and may have non-specific abdominal pain. If it's suspected, we would just empirically give a tablet to deworm these patients. Depending on parasites of the gut, certain parasites unfortunately can affect the central nervous system. It's quite a large topic that's a bit separate. So let's say not all worms for sure, but there are certain parasites of the gut that can affect the brain. And only if there's a really a concerned patient that we're seeing that has signs of central nervous system problems on imaging, one would then detect it and discuss that further.
Dr. Mullah, Jazakallah khair for joining the program this evening. Yes, and the questions are pouring in now, but unfortunately time's against us. To all the technicians at the various radio stations, thank you very much for a job well done. Time for us to bid you farewell, and from myself, Faisal MJ Suleiman, and the Medical Files team, we say Assalamu alaikum wa rahmatullahi wa barakatuh, and Jazakallah khair for